doing good? Guys, welcome back to Triple Two's YouTube series where we are going to master the questions, right? Clinical governance is a module which most of the overseas candidates study, but they are simple and straightforward if you know how the system works. And my effort in this video would be to revise and repeat the concepts what you already know and few things to draw your attention to. Remember, always difficult roads lead to beautiful destinations. So you must be feeling overwhelmed, especially when the exams are around the corner. Don't worry, this is just a phase. So keep believing in yourself and keep doing the work. Let's start off. So always remember consent questions are quite common. So as I always do here, what is the next best step is what they are trying to ask you. So a 32-year-old man undergoing TH for heavy menstrual bleeding. During surgery, 3 centimeters simple ovarian cyst is found. The consent taken before the procedure does not include the intervention of the cyst. So the point is, do what is consented unless it is emergency, which is life-saving. That's the first point. Second point, you can take biopsies without consenting. Okay. However, in complex ovarian cyst, if you're suspecting malignancy, you shouldn't be taking the biopsy because that can alter the stage. In this case, we are dealing with a very young patient who has given consent for hysterectomy, but nothing else, and you find a 3 centimeter simple cyst. So obviously, you would only do procedure as consented for, because without consent, you shouldn't be proceeding. But at the same time, you had the ovarian cyst, which was twisted gangrenous, then again, you would decide whether it is fair to go up now, detort the ovary and do an interval cystectomy. For example, I'm giving a very wild example. If you find an ectopic pregnancy, which you think should be done, otherwise she will go for rupture ectopic, you can go ahead and remove that, just to give a range of examples. So do as consented would be the best thing here. Okay, so here we are dealing with surrogate women. Please remember the principle. Unborn fetus has no right. Only the surrogate mother is the one who can decide what she wants. Okay, unless the baby is born. So what to do next? A surrogate mother carrying a baby has a 20-week scan showing echogenic focus in the fetal left ventricle. There are two things here, but she's refusing to inform the commissioning company. So this is a very, very normal finding, which could be a variant finding, but it doesn't mean anything. However, it's a mother's decision and it's a 20 weeks. So definitely as legally, she is valid for Clause C abortion law, right? And here she doesn't want to inform to commissioning couple. Of course, the point is whether the surrogate woman can carry on this is definitely, if you would of course counsel her with a counselor, with your consultant, but if that is what she wants, you have to go ahead and proceed as per the mother's wish. Remember, unborn fetus has no right. That is the whole principle behind this question. Next one, level of consent required. These are all which appeared in the last exam, guys. During a routine cervical smear, patient undresses and lies on the couch after the procedure is explained. No chaperone is present. This is something which is not correct, but you need to have a chaperone. But our question is not that. Our question is based on type of consent, whether it is written or verbal. Of course, for all these examinations and taking smears, you need to remember verbal consent is more than enough. However, the mental capacity of the woman, that is, she is able to understand what you're speaking, she is able to weigh the pros and cons, and she is able to communicate her decision, is what the mental capacity is all about. So here, if she has understood and she has given a consent, yes. Please remember, if the patient you are examining and some medical students are observing, you need to take the consent of the patient. It could be verbal consent is enough, but you need to take the consent of the patient. Okay. Next one. Okay. So here again, we are talking about a 12-year-old girl who is coming for termination of pregnancy, and she says nobody knows about it. What is the next best action? So less than 13 years, even the consensual sex is considered as rape. Obviously, here I can't see anything with police. Okay. You will check the capacity, but I'm not sure whether less than 13, they would be able to take any decision. So the best way forward is to seek the advice from the legal authorities, because according to Sexual Offences Act 2003, less than 13 cannot legally consent for sexual activity. However, what to do for her, whether to continue the pregnancy, whether to terminate the pregnancy, would be decided by legal authorities, that is court of law, with your consultant. Okay. And yes, definitely informing the parents for less than 12 years is less than 13 years. You can inform, because they are not legally, like they cannot actually do anything on their own. That's the reason you'll inform, but you have to take a legal opinion before you proceed. Next one, what is the most appropriate action for the doctor? A foundation year 3, that's an FI3 trainee, is on a flight when a 40-year-old passenger suddenly experiences giddiness, chest pain, and palpitation. Doctor assesses the patient and considers the treatment. This could be a very common scenario for us as well. So what is the most appropriate action for her? Of course, you can't decline being a doctor. Okay, you cannot refuse. However, you cannot wait. There is in flight, when you are in the middle of the flight, you cannot say that, let me wait for the help to arrive. And you can't ask the patient to give in writing. So the best is proceed in the best interest. So treat the patient under humanitarian grounds with insurance protection. Ideally, that's the only option which I can see. With or without insurance, you would be proceeding with a good Samaritan principle, because that is the oath which all of us take, isn't it? It's a very easy one. I don't think there should be confusion. Okay. Who takes responsibility for managing NHS units in case of pandemic? Okay. Guys, my previous RRR series talks completely about assessments. So if at all, if you are wanting to have a look into that RRR series, that would help you for all sorts of assessments and who takes care of what. Okay. So I'll ask the team to put the link as well. So please go through that. That could help you as well. This is very simple and straightforward. Clinical director is the one who will be taking a responsible for operation and clinical management, especially in case of pandemic. Okay. So please have a look into that, where I've detailed about what a clinical director, educational supervisor would be able to, would need to do as their, job description. Now, I think this is something which everybody is aware of, ARCP outcomes. So I think I have an EMQ also based on this. Let's see what is the problem here. Mr. Tom, an FI2 doctor, consistently fails to respond to pager calls during labor ward emergencies. He is under review at his ARCP. Please remember, anything which is recurrent, okay, will always come under outcome 3 for a lot of things, okay. So outcome 2, like, what I'll also show a slide about this. Outcome 3 ARCP is something which you will be getting when you are failing to operate in full-fledged, when especially when there are recurrent incidences. So that is the reason you need to be going ahead, where it means that you will be needing an additional time. Probably there's a training difficulty. Probably this is a bully training. That's all different. But what is the outcome? You'll be asked as outcome 3. Don't worry, I think I have a complete slide on different outcomes. Okay, Jehovah's Witness. Few things about Jehovah's Witness. Jehovah's Witness is a religious group where they are happy to take their own blood and blood products. They are not happy to take anybody else. Of course, they can take few things, but what they want, what they don't want, whether they would want to take in cases of life and death situation, is what are recorded in something called an advance directive. Okay. To give an advance directive, the patient must be 18 and above. Okay, so less than 18, nobody can sign an advance directive. So actually, even if they have signed, you can override in their best interest. Now, 17-year-old patient, placenta previa and active bleeding, is hypotensive and tachycardic. She refuses blood transfusion due to religious beliefs as a Jehovah's Witness. Obviously, if it was 18 and above, you will look into what you can do. You can do an intraoperative cell salvage or going for an hysterectomy. All that you would do either the ways, because to protect the patient. But here, because she's less than 18, you can proceed in the best interest, but you take 2 consultant opinion because it's emergency. In elective cases, you can actually take the court order so that you can proceed. Okay, this is something which all of you must be remembering. Of course, if you ask me termination, whether they can sign, yes, if they're competent enough, GILIC competent enough, they can actually sign. And less than 18, the thing is they can accept any procedure, they can sign if they have a competency between 13 to 18. But if they are less than 18, some procedure which is required for them in the best interest, they cannot refuse. What I mean is, for example, there is a rupture ectopic who is a 16-year-old and she has got a capacity. She says, I don't want to go ahead. In that case, you would refuse and you would go ahead in the best interest for the surgery, because these kids, you are not sure whether they are able to think good for themselves, even though they demonstrate the GILIC competency. Okay. Next one. I mean, mental capacity. That's what I wanted to say, the competence. Okay. Okay, what is the most appropriate next step? ST4 is performing an emergency cesarean in a woman with a previous scar. Okay. Upon opening the abdomen, they notice numerous tortuous veins covering the lower uterine segment. So when you're opening, you see a lot of tortuous veins because you've opened the tummy and you see a lot of vessels there. The 22-week scan showed a placenta anterior, but not low-lying according to her antenatal reports. What is the most appropriate? Whether you want to attempt the delivery through lower segment, you want to convert to an upper segment, you call the consultant, deliver through an upper uterine segment and wait, close the abdomen and plan for elective surgery, deliver through transverse fundal incision without consultant involvement. Most of them are safe. For example, option B, option C, because it's already opened and you're opening for emergency, guys. So obviously, out of these two, the best next option would be calling the consultant because you're an ST4. But at the same time, you have to deliver the baby quickly through upper uterine segment. And then once the baby is out, you can wait for closure and further any explorations if you require. So it's a very practical question. So remember this whenever you are in a situation where you cannot do much. Okay. The next one is, what is the most appropriate next step? 19-year-old with Down syndrome is referred to gynecology clinic with an abdominal mass that requires exploratory laparotomy. So somebody who might not have mental capacity because of the varying degree of IQ the Down syndrome people have. She lives in a residential care home and is accompanied by healthcare assistants. She has a low IQ as expected. So you are talking about a scenario where the young woman has got a mass with a low IQ and you have to do an exploratory laparotomy. Obviously, because it is nothing to do something which is an emergency. If it was a twisted ovarian cyst, you proceed with 2 consultant opinion and do it quicker. Because it's selective one, you take the court order or you would obtain a legal advice first on interpretation of the Mental Capacity Act and then proceed for consenting and then for the procedure itself as such. Okay. So as an ST5, you should know these requirements for women with mental capacity, without mental capacity. So that's why this question. Clauses. I think abortion clauses, you are all very well aware, but sometimes you are worried. So that's why I've given this. 35-year-old woman with 2 children, one of whom has severe Asperger. She unexpectedly conceives and is now 11 weeks. She says her current circumstances make continuing the pregnancy impossible. So what she means is she is pregnant now, but one of the child has got severe Asperger's. So she's worried whether she doesn't want to continue. Obviously, when the other children's health is affected and you don't know which way to go, you move to clause D, right? So clause D is for when the mother says that I'm happy for my pregnancy, there are no problems, but I don't want to continue because my other children will suffer because of this pregnancy. Okay. Simple and straightforward. Know these clauses because many times they do ask. Immediate appropriate course of action. 30-year-old undergoes cesarean section at 36 weeks for placenta previa. During surgery, significant bleeding occurs and a hysterectomy is required. What do you do next? Okay. So this is a scenario which we all can come across. Okay, what do you do now? The thing is, if a woman is bleeding, the prime thing is to save her life, right? So she might be in a position where you can talk to her and explain. Most of the time they are not if she's bleeding heavily. Then proceed now for the hysterectomy and then you can inform her post-operatively. Of course, you take two consultant opinion, all that's correct. And it is not that. That's what is called the duty of candor, being plain and honest after explaining. Of course, you don't take a consent from husband, from next of kin. No, you explain them, of course, but you are not going to take the consent from them because this is the best interest where you have to save the mother. Hope that's clear. EMQs. Okay, so EMQs, of course, there should be a leading statement where it says, what do you do for this scenario? Let's see. A surgeon diagnosed a girl with acute appendicitis. The signed consent included laparoscopy and removal of the appendix. So, of course, appendicitis has come. So, you're going to do a lap appendicectomy. Max to max, you can convert to laparotomy. That's what you have got a signature. Of course, I don't have an age of this patient. Intraoperatively, when the surgeon opens the abdomen, he sees a 4 centimeter cyst, and that's why you have been called. Okay. So now the surgeon is calling you because you are the best judge and you can decide what you want. So what do you do? Okay. So here the thing is, of course, there is no X and Y, they haven't named here. So I don't see this. So whether you want to abandon the procedure planned, consented for, procedure planned and consented for appendicectomy, and follow-up later versus. This is much more practical. And why I have given this as an option, because there could be a lot of other options, and why I'm choosing this is simple cyst. I'm not at all worried about this cyst right now. When the surgeon calls me as an obstetrician, I'll go have a look and I'll say, okay, fine, this is simple cyst. Don't worry, you can proceed with your appendicectomy and send me back for the follow-up cyst, right? So that is what you would be doing. Next one. 32-year-old woman is undergoing lap total abdominal hysterectomy for heavy menstrual bleeding. Signed consent for laparoscopy is removal of uterus and laparotomy. A simple 3 centimeter cyst is found on right ovary. I think we did this before also. This would be to only procedure as planned and consented for. Abandoned procedure doesn't suit here. Okay, so this doesn't suit here because 3 centimeters is nothing to do. So don't worry about, okay, what if and but. If you see dermoid cyst, actually, you can take a biopsy and confirm later on. But if you see something suspicious, something gangrenous, which you think will need intervention immediately, you can go in her best interest. Again, 2 consultants will take that opinion. Fantastic. So this is completely related to ARCP. So you need to know these ones. ST trainee has failed to pass part 1 MRCOG by the required time frame despite repeated attempts. Trainee has also failed to demonstrate satisfactory progress in other key areas. Obviously, the outcome would be 4. Please remember that one thing which you need to remember. Okay, let me finish first the ARCP outcome so that makes your life easier. Okay, this is what you would be doing for the outcomes. Okay, so outcome 1, you can proceed to the next level. Outcome 2, deficiencies training and need target training doesn't need extension. Outcome 3, deficiencies in training need additional training, but there are deficiencies. For example, this person is very, very good with skills, but he has not passed his part 2 or part 3. Okay, to move from ST5 onwards, you have to clear your ST3. I mean, if you want to move from ST5 to ST6 level, you have to clear your part 3 MRCOG. In spite of being perfect in all of the skills, if you don't pass, you would be still given outcome 3 because you need that 1 year or 6 months training or 6 months to write the next exam. So that's what they mean here. And outcome 2, deficiencies of training. For example, manual removal of placenta. This person is very good, but he is not able to clear summative manual removal of placenta because he is not exposed to lot. So what you do, no problem. You can proceed to the next year. But you have to make sure that you get this specific training, but there is no extension of the duration. That's what it means. Outcome 4, there are a lot of examples where the example which I quoted that they are not at all good in any other key areas and they are not able to pass even part 1 MRCOG. So you would give maximum training for 1 year and release them after 1 year. Outcome 5, you have submitted for ARCP, which you need to do every year. but the documentation are missing, so they cannot come to a conclusion. So they would ask you to resubmit. And then outcome 6 is a very good one where you are going to be a consultant. So let's see my answers. So here failing, see, if somebody has failed part 2 and they are not moving to, or even like I would say, like they are not able to pass part 2 exam, or they are not able to pass part 3 exams, okay? So if they're good in other skills, only this is pending, then they would give outcome 3, where they have to wait till, for example, Jan or July exam, they have to pass and then only they would be moving to the next, okay? But here, fail to demonstrate in all other key areas. So, and it is MRCG part 1, this fellow is not able to clear, then you release him from the training. Of course, this is done as a last resort, guys. Then ST2, has demonstrated good performance in formative OSATs and has failed 3 summative OSATs due to limited exposure in clinical practice. So this you need to be giving, sorry guys, this must be outcome 2. Just a minute. This will be outcome 2 because they are supposed to be giving you, specific training because you are good, but probably because of the less exposure you are not able to get any like perfection with that. So that's why they will be giving you outcome 2. Outcome 2 means you can move to the next one next year without the duration of the extension. Okay, so that's, as I mentioned to you, the MRP one. Okay, so the next one is, okay, sorry. Let me see. The TON forms, that is a trainer observation form, are a multi-source feedback where they have to take 10 forms and then submit for the ARCP. The sum of 10 forms is the TO2 score. So I just told you because I saw this, what they have given here. Trainers evaluation forms including negative comments regarding professional and behavioral communication. However, this is an isolated issue. That's what I'm interested in. Okay. Something which is isolated, something which is recurrent. Okay. Something which is isolated always will become outcome 2. Something, for example, if it is recurrent, this trainee always has a problem with professional behavior. He has a problem with communication. Then it would become outcome 3. Okay, especially these soft skills where they have been actually calling him for pager. Only once he couldn't come, but rest of the time is very good. That's which emergency or something like that. But that they would get as outcome 2, where they can continue the training to the next year with specific focus on the areas they lack. But if it is a repeated issue, then it would become outcome 3, where they get an extension of the duration of training as well. Okay, the next one is easy. Someone who has cleared MRCG and they are applying for CCT. Obviously, the last one, outcome 6. The next one, scenario 5, trainee submits incomplete documentation for ARCP. So the educational supervisor or the ARCP panel is unable to give you any outcomes for ARCP. Then it is outcome 5, where they would ask you to submit. Guys, hope this is clear. So if you still have a doubt, have a look into this. So what I mean is, without extension of training, they can move from ST2 to ST3 without any problem. But here, unless they clear those exams, they cannot move to the next year. Okay, I hope this is clear and easy. Okay, let me move to the next. Assessment tool. Okay. So Sophia Khan, ST2 trainee, has been reported by multiple midwives for her dismissive communication and poor teamwork during the labor ward handovers. Educational supervisor, Mr. James Patel, decides formally assess her interpretation skills from colleague to provide constructive feedback guidance. So obviously this is nothing but the TO form or the multi-source feedback, which you take from a lot of people to understand where do they go wrong. Okay. Okay. So the next one is, hope that's clear, guys. Remember TON, which I said TON is team observation forms. That's a multi-source feedbacks, because the midwife said many midwives have, her colleagues have told her that she's very poor with the communication. So how do they get in understanding is by collecting the multi-source feedback. That's the TON forms. Let's move to the next. Again, I'm dealing with appropriate assessment tool. Michael Smith, an ST2 trainee, caught removing negative feedback from his logbook to ensure only positive entries are seen during his ARCP interview. His educational supervisor, Dr. Priya Sharma, is concerned about this behavior and wants to address this formally. Whenever something like this happens, you would definitely bring this in ARCP, because this is a summative process where it is not only about the technical, but the softer skills also you need to be taking care. The next one, again, assessment tool. Dr. Rachel Evans, ST4 trainee, is assessed during a complicated cesarean section. Supervising consultant Mr. John Turner notes that while her surgical technique is competent, she struggles with teamwork, communication with anesthetist, and decision-making during an unexpected situation, which is nothing but simple and straightforward, the softer skills, which is nothing but knots. See, OSATs, she's perfect. The surgical technique, she's perfect, but she's struggling with talking to anesthetists, getting the right, probably she knows what to do, but how to communicate to the scrub nurse, all those things are softer skills, which is nothing but non-technical skills. Okay, I've added a detailed scenario so that you'll be able to understand. Let's move to the next. Dr. Lucas Walker, a ST3 trainee, is performing a vacuum delivery under supervision. Consultant Ms. Sarah Johnson wants to assess his technical skill during the procedure and provide a feedback. Obviously, any technical procedure which you want to give a feedback will always be an OSATs. Okay. Next one. So I hope you are clear about the formative or summative, which assessment tools you have got. Okay, guys, that's important. Okay, you are conducting an appraisal for a medical trainee who arrived late and smelled of alcohol. This is not the first time the trainee has been late, and their colleagues have reported multiple occasions where the trainee smelled of alcohol. It's not one time, it's multiple times. However, the trainee denies drinking alcohol on that day or day before. Most appropriate action. One time, alcohol, you can speak to him directly, but when it is not the thing, you are going to give a written warning and write it down on his appraisal notes. Ideally, as a co-colleague, if you are a co-trainee, you are going to write a letter to the educational supervisor because patient safety is at stake. Hope this is clear. Okay, this is all about, I think I'm talking about the surrogate options because that's important for you to know. Surrogate pregnancies, clinical, you have to choose the most appropriate action. Okay, this we already did, but let's see. 35-year-old surrogate carrying a pregnancy for commissioning couple undergoes routine 20-week scan, reveals an echogenic focus in left ventricle. I have actually highlighted, there won't be anything like that. This finding is explained to her as a minor anomaly with no significant clinical impact, but she becomes highly distressed, expresses strong desire to terminate pregnancy. The commissioning couple has not been informed of this development. Surrogate doesn't want to them involved in the decision, most appropriate action. So there are a lot of things here, but you know that you have to, you can letter allow to terminate, proceed with the surrogate's wish to terminate the pregnancy. This is there. Why I have chosen D, not as A. Okay. Here the problem is, of course, you will proceed with her interest. Finally, that's what happens. But here, there is a little bit of a friction. Generally, surrogate mother always talks to the commissioning couple. And if she doesn't want, she doesn't want. But here the problem is she doesn't want to inform anybody at all, right? So that's the reason you need to involve the legal advisory board to minimize the friction later on, and then you can proceed in her best interest. Or if she still insists, or if she doesn't want, you can take a decision based on that. The next one. 32-year-old surrogate carrying twins for commissioning couple, twins, at 25 weeks. She has developed severe preeclampsia and her clinical condition is deteriorating. The obstetrician team recommends delivery within 48 hours to protect her health. However, commissioning couples strongly disagree and insist that pregnancy should be prolonged for fetal benefit. Surrogate agrees with the medical team's recommendation, most appropriate next step. This is a very dilemmatic situation. Commissioning couple wants her to continue because they are worried about the baby, but here the mother is at stake, right? So remember, it's always some other safety comes into the picture. So obviously, you will deliver the baby immediately to protect the mother's health because her condition is deteriorating. Remember this, okay? Let's move on. 29-year-old surrogate is carrying a fetus of commissioning couple, attends a 32-week growth scan, which reveals bilateral ventriculomegaly, severe hydrocephalus after counseling. Okay, the surrogate expresses a firm decision to terminate pregnancy due to her concerns about the prognosis and her emotional well-being, which is fair enough. Commissioning couple, when informed, strongly insist on continuing pregnancy, citing the belief surrogate remains adamant about proceeding with the termination. So, yes, again, you could ask here that why I'm not going for taking legal advice from the NHS trust. Ideally, I would say that because there is a problem here, I would still say that it is better to take a legal advice and proceed with the wish to terminate the pregnancy if that was there, because there are a lot of things here. So I would still choose D here, even though I've given answer A here, because this is a 32-weeker. Okay, hydrocephalus is not something which is which the baby wouldn't die immediately, probably, we don't know. So they have to do feticide, and then they have to actually make sure that the baby is dead inside, and then take the opinion here. Because as I said for the first time also, I would like to change this because I don't want you guys to have a confusion. So if at all, if my answer, I would always proceed with this, that if at all, if there was an act which was there after legal discussion, I think I'm changing the option because I don't want you guys to get worried about the answer later on during the exam. So you can go ahead with this, which is the best one, which suits everything. Okay, so obviously in the exams, the questions are crystal clear. These are prepared by me. So when I'm explaining, I can see the conflict. That's why I added this. Okay. Few slides. Please note this. This is important. Mini-Kex. All this plus breaking bad news will be still Mini-Kex, guys. You need to know that. Case-based discussion is formative, discussion of the case which you did. OSATs is for technical, it could be formative, it could be summative. You know that formative is a friendly feedback to say you did this correct, you didn't do this correct. Summative is straight away giving fail or pass. ARCP is a yearly outcome summative format, summative assessment, which every trainee has to go through. That's what I said, the outcomes 1 to 6. Appraisal is for the consultants, which they need to do for summative. For the trainees, appraisals are there, which is with educational supervisor, which are formative, like 3 months, 6 months, they would be having. Revalidation. Every person who is registered with GMC has to prove that they are fit to practice, which happens once in 5 years. That's a summative one. Okay. So these slides are very important, guys. So please know them because they could be of great help to you. Incident reporting, you should know the few things which people forget. That's why I've added this. Readmission, blood loss more than 1.5 liters, shoulder dystocia, and then card pH, if it is there, and unavailability of health record is an incident report. So you need to know this. Medication error is also one of the things. Retained Faber instrument. These are important incident reporting things. Okay, guys, I have added like more than 10 SBAs and lots of EMQs for you to practice. Go through this. Hope this is of help to you because I've tried including recent ones and a dilemma ones and to make the concepts clear. Hope this is helpful. Don't forget to watch the previous RRR as well, which talks a lot about the assessments as well, so that you would be able to cover clinical governance in one go. All the best, guys. May success be yours. Thank you.